that wonderful talk of Srinivas's on artificial intelligence, go back to the bedside. And when we are doing CRRT, what are the troubleshooting that we need to do? It's not moving. Oh, okay, right. So this is what we would all like to see: a clean screen on our machine. All the pressures are in the green over here. There are no reds. The lights are flashing green, and there are no audible alarms. But as Dr. Kiran said in his earlier lecture, there is no magic or perfect machine or circuit, and this is not what we'll always see. So what we will get on our machines are 4 measured pressures: an access pressure, a filter pressure, an effluent pressure, and a return pressure. And the machine does that with the help of these pressure pods. So this here, before the blood pump, is the access pressure pod. After the blood pump is the filter pressure pod. On the other side here, with the where we would normally have an air bubble trap, we have a return pressure bubble chamber, and this is the effluent pressure pod. And as we can see, that is what gives us these 4 pressures. But the machine also displays for us 2 calculated pressures. You have a filter pressure, filter drop pressure, and a transmembrane pressure. Now, what are these? The filter drop pressure is the drop across the filter over here. So it's the difference is in essence between the filter pressure and the return pressure. And the transmembrane pressure is the difference between, as it is for any of our hemodialyzers, the difference between the blood compartment and the effluent compartment in this case. So the transmembrane pressure would be filter pressure plus return pressure divided by 2. That's the average pressure in the blood compartment minus the effluent pressure. And as we can see here, the effluent pressure is most often negative. So this is what we would get on our screen: 4 measured pressures and 2 calculated pressures. So we don't need to calculate the filter drop pressure and the transmembrane pressure. The machine does that for us, and all we need to do is to look at what the machine is displaying and act on the pressure changes. What are the determinants of this pressure? Our access pressure is determined by the blood flow we have chosen and the appropriate catheter length and the position of the catheter. A low catheter alarm, access pressure alarm, means that the access is failing to deliver the blood flow that we want at an acceptable pressure. Whereas a high pressure alarm would be seen in circuit leaks. And of course, if we have coupled our CRRT machine with an ECMO machine, then the access pressure, which after the centrifugal pump that we are taking our blood for the CRRT, the access pressure will be positive. We need to reset the access pressure at the start when we couple a CRRT with an ECMO in this situation. The filter pressure depends on the blood flowing through the filter. So the size of the filter, larger the size, more the blood flow required to maintain an acceptable pressure. The blood viscosity. So choosing a very high ultrafiltration rate will result in increased blood viscosity, increased filter pressure, and a higher chance of filter clotting. Return pressure is determined by the pressure on the return circuit, and accordingly the blood flow, and of course the return pressure will be increased when the chamber starts to clot. The effluent pressure is only determined by the effluent pump, which is driving the pressure, which is driving the effluent across the membrane, and it can only be high if by accident the line were to be clamped. A high transmembrane pressure occurs when a protein layer deposits on the filter, clogging some of the pores of the filter. And in this situation, the effluent pressure pump has to run faster to deliver the set effluent, and it does so by generating a higher pressure. And the pressure drop is a function of the filter. As more filter fibers get clotted, the pressure drop will increase with a lower pressure post filter in that. So the return pressure will drop and the filter pressure will increase, so that the difference between the two, the filter drop pressure, increases. This is what we will sometimes see on our screen. So the access pressure has become extremely negative. It's minus 256 over here at the blood flow that we have set. This has happened either because the access line is accidentally clamped. if when moving the railings of the bed, the line gets pinched between the railings, or if a patient is restless and there's a lot of movement. So a patient who's inadequately sedated, who's fighting with either his caregiver or is fighting, suction has been done and the patient moves, the access line accidentally touches the wall of the vessel in which the catheter has been placed, and there is a transient drop in the access pressure which takes it into this. Usually if it is due to patient movement, the pressure will come back to normal when the line comes back into the lumen and a self-clear attempt, as the machine says, is in progress. If the original alarm condition disappears within 15 seconds, the machine will clear this alarm on its own. Now, if the machine fails to has cleared the alarm, here you can see the access pressure has gone down back from -250 to -45. The machine will go ahead. We can use the continue button when the pressure reaches 0 and proceed. In this situation, something has gone further wrong and the machine is unable to self-clear the alarm. So this is not a question of a patient movement or a line accidentally touching the wall of the vessel. This is something that we have to decide that, and we have to take action on. It could be that we have inadvertently set a blood flow rate that is too high and our catheter is not able to deliver the rate that we have set. So we need to check whether there is a mismatch between the blood flow chosen and the catheter size. And if this is so, we go into the flow settings here. Here the blood flow chosen is 200. So mostly a catheter of at least 11 French or at least 10 French will be required. Most of our adult catheters are more than 10 French, 11.5 to 14 French. So such a catheter will, if for some reason the access is not able to deliver the flow that we require through the catheter, we either need to change the catheter or we need to lower the blood flow. So catheters need to be chosen for site. If they are placed in the right internal jugular vein or the left internal jugular vein, the tip of the catheter should lie within the right atrium, but not touching either the walls or the floor of the right atrium. The diameter should be 11.5 to 14 French, and we prefer double lumen catheters to triple lumen catheters. And ideally, a dialysis catheter should be sited as far away from infusion of drugs, nutrition, or blood products in the internal. If we are using the internal jugular for one of these, then we need to site our renal replacement therapy catheter in the femoral vein. This is what would happen in such a situation. So a patient has a sudden drop of blood pressure after connecting and starting CRRT. Does this mean that our inotropes and pressors are being cleared by the CRRT circuit? In actual fact, this does not happen. You can see that the volume of distributions of catecholamines are negligible. They are mostly metabolized at the site at which they act, that is the neuromuscular junctions, and they have extremely short half-lives, very short in the case of epinephrine and less than 2 minutes in the case of norepinephrine. So in most circumstances, a CRRT will not increasingly clear inotropes. But if we have placed our catheter here in the superior vena cava, and we also have our delivery of drugs, of inotropes, of nutrition, etc., into this same site, then these will be pulled out of the patient and into the extracorporeal circuit before they have a chance to reach the site of action. So in this situation, it's better to site our catheter at a safe site for a dedicated RRT catheter in the femoral vein and make sure that it's long enough to reach the IVC. These are actually case reports of things that have happened in such a situation. This is a cardiac arrest which happened in a patient who was started on CVVH because the RRT catheter dragged out all the inotropes and the patient's blood pressure suddenly crashed. So it's necessary, and so is this. When drugs disappear from the patient, intravenous medications pulled out by hemodiafiltration. So it's necessary to be aware of this when performing a renal replacement therapy or CRRT in a patient on very high inotropes. Okay, if we have tackled the problem, the access pressure returns on such a situation to a positive value. We press the continue button at the bottom of the screen and the machine will go back to normal functioning, where a mildly negative access pressure is acceptable. So here is an access pressure of -66 at a blood flow of 200 mils per minute, which is quite acceptable in this situation. This is the opposite situation. We have a return pressure which is extremely high. The return pressure is 403, well into the red, which means that the return line, something has happened to the return line. Now, because the return pressure is normally at a positive level and it is after the blood pump and the filter, a clamp exists on the return line to prevent any dangerous situation like clots and air reaching the patient in an alarm situation. So as soon as the return pressure goes out of range, the line will be clamped in such a situation. And so a self-clear cannot be done with return pressures in any situation, because until we use this button at the bottom to release the clamp, the machine cannot drop the pressure to a normal level. When we do that, the pressure, if the alarm condition has disappeared, the pressure comes back to zero and the continue button is now available to us and we can restart the circuit once again. So this is the situation here. And now we have at a blood flow of 200, we have a return pressure of 110 to 115, which is acceptable. We need to remember that when examining an arterial pressure alarm, that arterial pressures are all negative. So we need to ensure that if we are checking the catheter, that we clamp all the lines on the access side. If we don't, then this is the next alarm we will get, air in blood. Because the moment we release the clamp on the arterial line, if the alarm condition has not disappeared and if a saline is not connected to the circuit, the machine will suck in large amounts of air. And in this situation, when the air reaches the air replacement fluid interface, it will push the blood level down and we will get an air in blood alarm. This is the air bubble chamber. It's not actually an air bubble chamber. Unlike our dialysis circuits, there is no air-blood interface in normal functioning. What we have is blood entering the chamber from the bottom of the chamber and a layer of replacement fluid which is delivered over the top, preventing air and blood from coming into contact with each other. However, if at a point in time, the bag was not changed in this situation, or the bag was changed well after it got empty, air could be delivered in by the return line into this chamber. An air blood foam gets formed, and some of these foam bubbles enter the air detector just below this chamber and trigger off the air alarm. See, here you can see what is happening. At 11:26, the machine said, caution, PBP bag empty. At 11:29, the bag had not been changed. So 3 minutes later, for 3 minutes, small amounts of air, depending on the rate of PBP fluid, have been sucked into the circuit, and these will eventually course through the filter and reach the air bubble chamber. So it may be that even after the bag has been changed, several minutes later, we may find ourselves getting an air in blood situation. What do we do in such a situation? Create a negative pressure using this up arrow on the right hand side of the screen to make the pressure in the venous bubble chamber negative, in the return chamber. When this is made negative enough, this button at the bottom of the screen saying release clamp gets highlighted. So in this situation, we press the release clamp button and the machine will draw up blood from the return line until the air is removed from the return chamber. And at this point, the return pressure has dropped back to a positive value of 4, and the continue button has now become highlighted, and we can press the continue button and return to normal operation of the system. And here you can see that is exactly what has happened. The machine has returned to normal functioning with all the pressures in the green. This is a message that we would not like to see. The circuit has clotted. There is nothing that we can do. Clots are formed in the filter, and the machine tells us press stop and change the set. There's nothing much we can do once this alarm happens on our CRRT machines. So we need to take action to prevent this from happening. And the way to do that is by optimizing the filter life. So we prevent circuit clotting and filter clogging. Adequate blood flow and vascular access, as I mentioned earlier. And then we need to minimize our filtration fraction. The filtration fraction, the official definition of the filtration fraction is the ultrafiltration rate divided by blood flow rate into 1 minus hematocrit, and it needs to be targeted to less than 20 to 25%. As the effluent is the dialysate flow plus the replacement fluid flow plus the patient fluid removal, the filtration fraction does not include the dialysate flow. So PBP rate, replacement fluid rate, patient fluid removal upon the blood water rate and the PBP rate gives us the filtration fraction. Fortunately, again, we don't need to calculate all this. Here you can see in the machine screen, on its prescription screen, it is telling us that the effluent dose is 3,250 ml per hour. The effluent dose is 50 ml per kg per hour. The ultrafiltration rate, which does not include the 50%, which is the dialysate flow, is about 23 ml per kg per hour, and the filtration fraction is a satisfactory 17%. So in this situation, we would be fairly safe. We need to look at, therefore, and monitor our pressures from time to time, and we can use the history button at the bottom of the screen to go here and look at what events are happening in our circuit in order to monitor it and prevent the circuit from clotting. Now, here we can look at a screen, and I have chosen to look at the patient fluid removal. Look what's happening here. 0 ml in this hour, 50 ml of fluid removal here, 62 here. At 11 o'clock, it's 46, and at 12 midnight, it's 58. But at 10 p.m., for some reason, there was 155 ml of ultrafiltration removed. Now, it's quite clear that we must have set something like 50 to 60 ml, but here the machine took out 155 ml and it did not alarm. There was no alarm in our monitoring screen over here during that period of time, and yet the machine took out 3 times what was set. The reason for that is that the machine averages over a period of 3 hours the unintended patient fluid loss or gain. And here it says that all that happened was a patient loss unintended of about 3 ml in the last 3 hours. So this was counterbalanced by the fact that the machine took out less in the previous hour, and so it did not alarm. But this could be extremely dangerous to our patient. Look at this, it's even worse. Here is a patient in whom we are trying to ultrafilter, and yet at 11 a.m., the machine actually made the patient positive. 79 ml of extra fluid entered the patient rather than an ultrafiltration being removed. So here we have a situation which is unacceptable, and yet the unintended gain over the last 3 hours was 0 ml, and so the machine would not alarm. Now we can set and select our limit. But just before we prescribe our treatment, this is the screen after the self-test that appears on our machine. The machine tells us that it will normally, by default, based on the patient's weight, accept a value of an unintended fluid loss or gain of 400 ml over a period of 3 hours. But depending on the patient's clinical condition, the machine allows us to change this limit. And of fluid error. So I go into that, I use the arrows at this side, and I can change the value. Here it's 300, and I can go down further and ensure that what I'm setting is correct. We need to remember that a kinked line on the bags, a bag which is partially supported, or a bag which was accidentally pulled or traction given by a nurse or an attendant, may result in transient wrong readings as regards the fluid loss or gain. We can check the history of what is happening to our treatment at any point in time, as we can see here, and we get 3 different color-coded types of events which happen. Operator events are coded in blue, the setting events are coded in white, and the cautions or warnings given by the machine get coded in yellow. None of these will produce an audible alarm, and that's what I'd like to see. Here you can see plenty of cautions are happening, but there are no alarms. But not here. Here we've got events which are coded in red. So axis extremely negative. So the machine started here at 1909, that's 7:09 p.m. with an advisory to check the axis. And a few seconds later, because the axis pressure went too low, we got an alarm which stopped the pump. Now, frequent stoppages of the pumps will eventually lead to stagnation of blood, maybe anticoagulated, maybe not anticoagulated, and result at some point in time in an alarm with a circuit that is clotted. Here you can see axis was extremely. Now, this is what I can trace. On this occasion, at 2:30 in the night, I got a phone call from from one of the ICUs. There was two simultaneous CRRTs running, and they said there's an access pressure there's a return pressure that's extremely positive. And I told them what to do. And the next morning, I had no idea which patient this had happened to. So when I came, I could go into the history and check which patient it is and monitor accordingly. Another thing that happens is I can check. I was told at 7 p.m. in the evening that the machine failed the self-test. So the machine performs the self-test every 6 hours during a treatment. And if it fails the self-test twice, you can see it failed it here at around 3:43, then the machine will stop the circuit after two such events. So what do? I use the first facility of system tools at the bottom of my main screen. It takes me to this screen where I can initiate the self-test for myself and find out why it failed, start test, and the machine performed the self-test. And at 7:24, it initiated the self-test, and at 7:28, it completed the test successfully. So there was nothing wrong with my circuit. It was something transient, and the machine is allowed to go forward. This is the sound check. This is part of, we've heard about artificial intelligence. Most RRT machines have what is called as a fail-safe system. So at the start of a treatment and every 24 hours, the machine will produce a beep which it has to detect itself to know that its audible alarm system is working. And here it says the startup sounds were not detected. And if this happens, we can either retest over here, and if we fail the retest, the machine will make us disconnect the circuit, as it is unsafe to perform a treatment where audible alarm systems are not working. So this can happen because either there is too much of ambient noise in the ICU, there are ventilator alarms going off, there are cardiac monitors which are alarming, and the machine is unable to detect its own system, or this is the power supervision board on the inside of the Prismaflex machine. It has a small microphone which detects the beeps given from the speaker. Now, if the microphone is not working, the machine will fail the sound check test, even though we may actually be able to. So this is the microphone, and it has failed to detect the sound. And in this situation, the microphone needs to be repaired or the board replaced. This is another message that the machine says the wrong set has been loaded. And why does this happen? When we start our treatment, we can go to the therapy info and check whether the treatment that we are choosing and the set that we are using are compatible. So here we have a choice of treatment, CRRT, and we have a choice of sets, CRRT sets, which we can use for the selected treatments. So I've chosen CVVH-DF, and then I have a choice of sets. So I'm going to choose M100 here. And if the two are compatible, I don't need to know anything further. The machine will tell me the specifications of the set and what sort of settings I can use in terms of blood flow, dialysate flow, ultrafiltration, and replacement fluid. If these are not compatible, then the message on the screen I showed you earlier will be given that the set and the treatment have chosen are not compatible. Of course, it's necessary, therefore, to configure the machine to deal with all the sets that we want to use, which we can do through this menu. And so in summary, the machines measure multiple pressures and calculate pressures during a CRRT treatment. A functioning, appropriate vascular access will preserve our filter life and achieve the treatment goals and minimize alarms and stoppages. The prescription must optimize filtration fraction and modality. Machines will work in a fail-safe mode with zero error tolerance. That is what makes them safe. It's said that the problem of a patient facing a complication due to machine malfunction is around 1 in 100 million, which is less than the risk of dying in an accident while crossing the road. But in spite of that, monitoring and continuous surveillance are required. The human factor is required to ensure the best results. Thank you for a patient listening.
Thank you, sir, for this, I would say, so well narrated, and it's like a story, and you have made the difficult job so easy. So any comments from the panelists, anything they want to get clarified, or they want to have some like feedback? Dr. Flavio, Dr. Mukunda, Dr. Ranajit, Dr. Sanjay.
It was a great talk. Congratulations.
So, sir, if you want to advise to the trainees, because the problem is the trainees, they don't get that type of training in their like limited 1 year, 2 year of like critical care fellowships, or like their super specialty training. So what should be the way out so that they would be more confident in handling this troubleshooting in CRRT?
Yeah, okay. So that's a difficult question. I think you got to make the most of the opportunities. So whenever a CRRT is running, visit that machine several times a day. That's how I learned 25 years ago what I would do. And the machines were not as good then. They didn't store the information for more than 24. They didn't even store it for 24 hours in those days. Some of them were machines that we had made ourselves from the components of old dialysis machines. But today you have software, you have machines which have great memories. You can collect the entire information with a pen drive, take it away and study it at leisure. So all this is available on the machines today. We can collect all the information before the next patient treatment. What I would say is visit the machine several hours a day, go into the menus of the history, look at what the events which have happened. What I could not show you for lack of time was the machine will also give you pressure graphs. It will show you how the pressures have been behaving over the period of the treatment. We can visit that, we can correlate the events and the pressure events and learn. So if you say, how do we learn? The only way to learn is by doing and by doing and visiting the machine again and again and again.
Yeah. Thank you, sir. And with this, we come to end of the 3 keynote talks. Now it's the time for the journal scan, or I would say journal club. And 2 of our young dynamic intensivist